Alex Crossley. Wishing everyone an enjoyable and inspiring session. Thank you.
And now we move to our first nominee, an initiative that transforms memory, silence into dialogue, and pain into hope. Our next nominee reminds us that human rights, dignity, and health are deeply interconnected, and that remembering is, in itself, an act of resistance. Echoes of Justice, Memory Does Not Disappear, Justice Unites Us by AMIF Mexico commemorates the International Day of the Victims of Enforced Disappearances through education, reflection, and community engagement. Centered around the pillars of memory, justice, and prevention, it honors its victims, supports families, and inspires future healthcare professionals to become advocates for truth, accountability, and human dignity. Because memory does not disappear and justice unites us. Please join me in welcoming AMIF Mexico.
Dear IFMSA family, dear judges, imagine waking up tomorrow and having your very beloved one just disappear and not knowing what to do. Over 115,000 families in Mexico live this reality. Enforced disappearance is a very problematic human rights and also global health crisis. In medical education, this topic, it still remains invisible. And health professionals are often the first contact with the families that are affected. But we, as health professionals, receive zero training in informed care or either in specialized protocols to avoid re-victimization. To bridge this gap, SCORP of AMIF Mexico has created Echoes of Justice. Next, please. Next, please. And next, please. Next, please. Our initiative is built in three main pillars: memory and visibility, justice and accountability, and prevention and psychological health care. We moved beyond one single lecture and designed, please next one, a four-step implementation model, which carries many activities that gather psychological webinars and workshops, memory in action, screenings, voices of rest, means to have communitary interventions, and also trainings specialized in empathy and re-victimization, non-re-victimization trainings. Next, please. We gather very multidisciplinary alliances with professionals like psychologists, laws, and professionals in communication alongside universal entities such as the United Nations Commission of Human Rights and also the Red Cross. But we also give voice to local collectives such as Madres Buscadoras, which is our research local collectivity, to hear out of them the real and local situation experience in Mexico. Next, please. We gather our students, we gather our association, and we gather all these collaborations to bring a sensitive and informed information to our participants to raise awareness of this situation happening in Mexico. After all, we are very happy to say that according to this four-step implementation model, we had success of implementing this activity in 17 local committees of Mexico, which has been one of our greatest initiatives during this term in AMEF Mexico. We evaluated this activity by providing pre and post evaluations to our participants to evaluate the ethical, the psychological healthcare interventions, and also the practical workshops offered to them. And we got a great success. We got 275 certificated participants
Excuse me, the time
who
is
were
up.
beneficiated
Excuse
from
me,
this
the time
activity.
is up. Yeah, time is up.
Thank you.
Okay, now for the judges. Do we have any questions?
So, hello, this is Sadat, he, him. So I want to ask you, like, how do you think this project, like, helped in achieving the goal of our Think Global, Act Locally? And how many local people were involved in the process?
So can you repeat?
How many local peoples were involved in the process, like in your LCs or?
Thank you very much for your question. This activity aimed to raise this awareness, this information provided to healthcare professionals who at the end of the day are the ones who are at the front of the families experiences this kind of situations in Mexico. And we want our health professionals, our future doctors, to be prepared to provide psychological first instance care, to provide the right things to say and how to provide this accompany to the patients who are facing through these situations. We are happy to say that it has success because we apply our evaluations to see how people were retaining this information, and more than 70% of the knowledges were acquired of our participants. In first instance, we had a participation of 275 participants who were involved in the first stage of the project, but after that, how I have already told you, it was implemented in other 17 local committees of AMEF Mexico, thanks to the four-step implementation model, because in AMEF Mexico we also protocolized this activity and also enroll it like nationally, after that internationally, and that helped us to replicate the activity easily with our local officials in each local committee, and to do it at the end of the day more nationally and to have a bigger and bigger success and impact in more participants.
Okay, thank you very much. Do we have any more questions? Go ahead, Miko.
Yes, so my question is about your plans to scale this activity and try to develop it further. What are your plans to both expand it in terms of perhaps the number of local committees that are addressing this issue, but also in terms of creating like a workforce, like a group of people who are capacitated and who can then carry this knowledge forward. So have you been thinking about this, or maybe you've already taken some steps? Because whatever you do is important, but then this knowledge needs to go further outside of the scope of the activity. So what have you done in that regard?
Okay, thank you. So our future action plans, it's that basically in Mexico we have also a national day of enforced disappearances. We are planning to get in contact with our local committees through our NORP to make them have this approach on this day and to gather all our local committees to do these activities simultaneously in many parts of Mexico, because at the end of the day, that's what we want. We want to replicate this activity and to let other local committees in an easier way, in an informed way of having this protocol already established to apply this activity following the same standards as it was initially. We, during these 4 days plan activity, there were many capacity building actions as well to capacitate more students, like to be able to continue with the efforts of this activity and at the end of the day replicate from themselves different trainings specialized in, how I already said, in empathy, legal literacy, and also psychological healthcare provide.
We have 17 more seconds. Do we have any more questions? Okay, that concludes. Thank you so much, IMF Mexico. You've been amazing. A round of applause.
Hi everyone. For our second activity today, we have an activity presented by IFMSA Indonesia called BONU. BONU, or Promoting Community Knowledge and Care for Youth and Children on HIV and AIDS, is a community-based initiative designed to improve support for children living with HIV in Samadan Residency, Indonesia. Through a field assessment, they identified 25 children in need of continuous support and found important gaps in HIV status disclosure, caregiver support, and community engagement. To address these challenges, they implemented 3 key interventions: a public webinar on pediatric HIV, home visits to assess the needs of children and their families, and a communication workshop for AIDS care community, or CARDS. The purpose of BONU is to strengthen the capacity of communities to provide informed, compassionate, and stigma-free support for children living with HIV, helping to create a safer and more supportive environment where every child can thrive. Please welcome to the stage IFMSA Indonesia presenting BONU.
Thank you so much. My name is Naifa. I'm from IFMSA Indonesia. So first, let's play a game. Simon says, raise your hand if you know what HIV is. Okay. Simon says, keep your hand up if you've ever met a child living with HIV. Okay. So that's exactly what PONYO is. PONYO stands for Promoting Community Knowledge and Care for Youth and Children on HIV and AIDS, presenting by IFMSA FK Unpad. Next slide. Why we choose PONYO? The reason is because in Sumedang Regency, 25 children and adolescents living with HIV. That means that there are so many children that need continuous support by the cadres. So that's why IFMSA Indonesia, which is FK Unpad, we build the capacity building for the cadres to support the children living with HIV. Next slide. We also conduct a pre-activity assessment with the result that 25 children living with HIV identify required intensive and sustained community-based support. And also, by the assessment, it says that 17 the cadres, WPA Sumedang cadres interviewed through directly video calls by 22 sekolah IFMSA FK Unpad members. Next slide. By the KIP theory, this is the result, and by these findings, we highlighted that the need for a structured capacity building program tailored for the unique needs of children living with HIV is needed. So that's why PONYO is happening. Next slide. The goals of this program is to implement a series of interviews, including a public lecture, panel discussion, home visits to children living with HIV and AIDS, and a workshop with Warga Peduli AIDS or WPA volunteers from February to March in 2026. And by this program, we want to facilitate the cadres to support the children. Next slide. This is the objective, to enhance the knowledge of and awareness of Sekolah IFMSA FK Unpad members, to increase the sensitivity and empathy of Sekolah IFMSA FK Unpad members, and to reduce HIV-related stigma. And for the practice is to equip Sekolah IFMSA FK Unpad members as peer educators with empathetic communication skills and a collaborative approach to HIV and AIDS. Next. And this to improving nation's health, to strengthen the capacity of Warga Peduli AIDS in supporting children living with HIV, to foster empathy, promote non-discriminatory, and also to strengthen the capacity of Warga Peduli AIDS in providing biopsychosocial support, communication, and advocacy. Next slide. The targets is 70 cadres from Sumedang, and also we also have 35 webinars participants with IFMSA program HIV and AIDS and others, and the focus area are these. Next slide. This is the methodology. We have three main methodology. There are pre-event, main event, and also post-event. In pre-event, we have needs assessment, which becomes the background of this event. And also for the main event, we have public lecture and panel discussion, home visit, and also workshops with the children living with HIV and also the cadres. And for post-event, we have after movie and follow-up. Next slide. This is the pre-event. Next. Next. This is for the main event. We held a webinar in February 7th, where there is a public lecture and panel discussion held by Dr. Arta Kamelia from UNICEF Indonesia, and followed by a session on updated on pediatric HIV presented by West Java doctors community. And next slide. We also have the home visits were conducted with Warga Peduli AIDS, which is the cadres, for 5 children living HIV in Sumedang, which also in addition there's a biopsychosocial assessment carried out with the
Time
children
is
and their
up.
families.
Thank you very much, Chimsa Indonesia. Okay, now for our lovely judges, do we have any questions?
Thank you, Simsa Indonesia, for the nice presentation. So I wanted to ask, what was the problem statement for this project? Yeah, like I want to understand, if you have statistics of how many children experience this issue, that's why you started this initiative or anything, yeah.
It's already stated in the slide that there are 25 children living with HIV in Sumedang, but on this program, we're focusing on 5 children, which is on the home visit to, yeah.
Okay, sorry. So I want to understand if you have any statistics or anything that support why you started this project. Like, why do you want to promote, yes. Or
Okay,
why you want to
could
do
you
this?
please click the previous slides, the previous, I think like on the first view, more. Again. Okay, so the reason, the statistic is from the pre-activity assessment. We conducted it, and it shows the result that there are 25 children living with HIV identified co-intensive and sustained community-based support. Next slide. And also, next. We also did a assessment by KAP Knowledge, Attitude, and Practice Theory, where it says that 94.1 out of 100, but 40% had never disclosed HIV status, and more than 80% lack confidence in disclosures. And also by the community readiness assessment, says that community readiness only 9.57 out of 9, with community climate 4 out of 9, and also many cadre experience emotional burden and uncertainty when supporting HIV and their families. So by these findings, highlighted that there is the need for a structured capacity building program tailored to the unique needs for the children living with HIV.
Okay, Ron, go ahead.
Thank you for your presentation. Can you tell us more about the short-term and long-term outcomes of their event?
So for the long-term impact of this activity, the expected impact of Ponyo is to establishment of a stronger and more sustainable community-based support system for children living with HIV in Sumedang, where through continuous capacity building, the WPA cadres are expected to provide more confident, empathetic, and evidence-based psychosocial support, particularly in communicating with ADHIV and their families and facilitating appropriate HIV status disclosure. In addition, the biopsychosocial profiling archive developed through Ponyo serves as a long-term resource for individualized care planning and future community interventions, where medical student volunteers also gain valuable competencies in community development, needs assessment, and community-based HIV advocacy, enabling them to design and implement more evidence-based public health interventions in the future. And for the short-term impact, there are, should be in the slide, but 100% the cadres were engaged and completed their pre-assessment, where there is 8.27% average increase between pre-test and post-test scores, and also 20% of children living with HIV condition in Sumedang were mapped, 3.4% overall participant rate.
Okay, thank you so much. We have one more question. You have 30 seconds left.
Okay, so I will try for my question to be able to be answered in 30 seconds. So I wanted to ask more about evaluation of the home visits, because you've touched upon the home visits. There wasn't enough time to dwell on that. So the house environment might be challenging, and there could be some difficulties in standardizing those visits. So what kind of steps did you take to both standardize, so that unify the experience for during all home visits, but also how are you evaluating whether those activities in these environments are bringing any good effects, and whether there's any impact?
Is there any challenge that we face during the activity? Yes, there's definitely. Since the WPA cadres also have another thing that they have to do. They have to balancing out during the activity and also their work. And also for the organizing committee, they are not based in Sumedang. They are based in the somewhere other place that kind of far from Sumedang. So that's also becoming one of the challenge. And also, yeah, I think those are the challenge.
Okay, right on time. Thank you so much, Chimsa Indonesia. A round of applause for them, please. Moving on to our next activity.
Hello, everyone. Our next finalist is Crossley, Croatia, with the campaign called Out Cancer It. This project is all about raising awareness of HPV and encouraging HPV vaccination to help prevent cancer. It's a real proof that education really can save lives. Let's give a warm welcome to Crossley, Croatia, and stage is yours.
Next slide, please. So, good evening, everyone. I'm Jago from Crossley, Croatia, and today I'm going to present to you a project that we are really proud of. It's Out Cancer It, and I sent some brochures. You will see it when it reaches you in the room. Next slide, please. So you all heard about HPV. It can affect anyone. It causes 6 different types of cancer. It affects 80 to 90% of all sexual active people. The problem is that there are some myths that it can't affect men, but actually it can. And it's sometimes more severe because women have actually the screening, which men don't. And all of these problems actually can have a solution, which is prevention. So the only problem is that vaccine remains surrounded with some myths and with stigma, which we are trying to break and let it go away. And of course, we're trying to reach the WHO 90% goal. Next slide, please. So our project is active mostly in 4 cities where we have medical schools. Makes sense, but we didn't let that limit us, so we went broader to another cities, and we even managed to do like the online workshops. Other than that, this year we had more than 400 workshops conducted, reached more than 10,000 pupils, and we trained more than 150 educators. And our partners, you can see them here, I don't know, I will just tell you that they're like significant health institution which help us with the credibility and visibility. Next slide, please. So, what makes us different? I mean, a lot of things, but we had to point out a few ones. Peer education, no need to explain, because it's easier for you if you hear something from someone similar age. Then we have podcasts and influencers, because let's be honest, these days, children and youth are scrolling on their phones, so why don't you use that and turn it into something like impactful, something that will teach them. Other than that, we reach parents too. We educate them too, because our main target group is minors. So if you want them to get vaccinated, you need parents' consent. So why don't teach parents so they can actually make their informed decision. And other than that, we're trying to like catch the age gap between 18 and 25 years old for those who miss the school vaccination. And we do it like with pub quizzes, some vaccination points on campuses where students are present. Next slide, please. So here you can see our little photo gallery. I tried to include like the very different things we actually do in our project to reach as much groups as we can. Next slide, please. And the impact we make. So every year that we exist, I mean not only exist, every year we work, there is like a higher rate of HPV vaccination in Croatia, and we didn't make that up because we are, oh my god, so cool. There are actually numbers, and if you make a comparison, you can see that there is like 700% higher rate of vaccinated citizens than previously. Other than that, the national televisions calls us for statements. They call us for like the panel discussions, and something we're proud of. We don't reach out to schools, they reach out to us, so we made an impact. Please, next slide.
Thank you so much, the time is up.
Oh, okay.
Okay, now time for questions. Okay, time for questions. Do we have any questions from the judges? Okay, here you go, Erin.
Thank you so much for the nice presentation. So my question would be, like, you have a lot of activities that you're implementing, so how do you assess the outcome or maybe the impact of these activities that you're doing?
Thank you so much for the question. This was this slide, how it lasts for 10 years. So we have the pre and post evaluation, not only for the trainers to see like their opinion on the trainings, the workshops they gave, but also like the participants, and it's implemented in the presentation. So you go into a classroom, you have, and it's all like with colors, so it's tailored to their age, and they answer the questions. And after that, you do the interactive presentation, and after that, you also has, and it's not like something boring exam-like, so it's more sustainable. You have a mentee, and then at the end, they answer the same question, and then you can make actually a comparison, how much did they learn, and if we round it, and kids really learn fast, it's around 80% increase in their knowledge. And yeah, I hope I answered the question. Thank you.
Okay, perfect. Thank you so much. Do we have any more questions? Okay, go ahead.
Thank you once again. You gave us amazing flyers here, so I wanted to also know, how do you ensure that your project is eco-friendly?
Oh, thank you. Excellent question. So I already started it. The surveys or the Google Forms and everything, we don't print them. And also for pupils, it's all like in the presentation, so you have it with you. Other than that, oh yes, we have our webpage and some like sustainable resources. We have our Instagram account, our Facebook account. We have, you can see it here, budimrak.com, which is a webpage where it contains all the information. Other than that, we have another webpage on our Chromesic account where you have like some videos that are educational, etc. So it's mostly digitalized. And yeah, I think that's it. Thank you.
Okay, do we have any more questions? Okay, Miko, go ahead.
Thank you. So a very short question. You mentioned the institutional partners that are helping you implement the activity, but also I wanted to ask whether you have any support from like private actors or from any sort of companies that are helping with the activity. Sorry?
Okay. Thank you so much. I was hoping someone will ask this question because I clarified it while I was applying this. So we had, other than the institutions that are here, we have a big sponsorship from MSD. And actually, I want to clarify because it is a pharmaceutical company. There is no conflict of interest because it is the only company in Croatia that has HPV vaccinations. So that's why we accepted the sponsorship. And thank you for it.
And there are no strings attached to that. There are no strings attached. I understand.
No,
okay.
Thank you.
Okay, any more questions? We have 50 seconds left. Okay, anyone? Going once, going twice? So thank you very much, Cromsec Croatia, and a round of applause for them, please. Okay, moving on to our next activity.
Our next activity comes from Hungary. Prevention classes is much more than a health promotion program. It's the result of years of dedication, collaboration, and the passion of hundreds of medical student volunteers committed to creating healthier communities. By bringing interactive evidence-based health education into classrooms across the country, this initiative has empowered thousands of young people to make informed decisions, adopt healthier lifestyles, and become advocates for future. It's a wonderful example of how prevention begins long before the hospital and how students can create a long-lasting impact through education. Please join me in giving a warm welcome to Hungary.
What if a single classroom section could prevent a heart attack 20 years from now? What if one conversation would inspire a teenager to donate blood or save someone's life by performing CPR? Hello everybody, my name is Pisti and I'm proud to present our activity prevention classes. Next slide please. Hungary has the second highest rate of avoidable deaths in the European Union, being double than the EU standardized death rate. Most of these deaths come from preventable lifestyle-related conditions. Next slide, please. But still, our school curriculum provides minimal health education for the children and the youth. As medical students, we realize this gap, and that's why we designed prevention classes activity by building health together to empower the next generation. Next slide, please. We aim to create a national activity involving all 4 of our local committees by targeting the children and the youth in Hungarian schools. Our goal was to teach them how to protect their own health and also how to uplift their community's well-being, therefore broadening the beneficiaries group to the general population of Hungary. Next slide, please. Our main objective was to facilitate over 1,300 prevention classes in all topics and locations in this term. Next slide, please. But we also had several other objectives for locations. Next slide, please. And also for health topics and behavior. Next slide, please. Next slide, please. One more, please. And one more. And very last, more. And one more, sorry. So what makes our activity unique is that we do not focus just on one or two topics. We focus on 10 core public health pillars, from healthy lifestyles to communicable diseases, to basic life support, to reproductive health, to substance abuse, to empower the younger generation. Next slide, please. To ensure our high quality, all of our presentations reviewed by the 4 Hungarian medical universities, and all of our trainers must complete full training and graduate through a simulation to become prevention trainer facilitators. Next slide, please. From the evaluation methods, I'd like to highlight the continuous monitoring during the class and the evaluating Google form after the class for students. Next slide, please. And I think the impact speaks for itself. In this term, we were able to facilitate over 2,271 prevention classes, reaching over 45,000 young people. If we put it into perspective, in just 8 short months, we were able to reach 0.5% of the total population of our country. Next slide, please. But we are not just delivering classes, we are driving real behavioral changes. Next slide, please. And next slide, please. To ensure that our activity is sustainable, we created a huge group of facilitators, and we conduct trainings in every semester and with every topic in every local committee. Our activity has been going on for years, and we plan to continue it further. Next slide, please. Prevention doesn't start in the hospital, it starts in the classroom. Through student-led action, we are changing the health culture of an entire generation. Next slide, please. Thank you very much for your attention.
Right on time. Thank you so much. Okay, do we have any questions? Okay, go ahead, Miko.
Thank you for your presentation. Your presentation mentioned a lot of topics, different topics, sometimes topics not really related with one another. So if you were to name 2 or 3 major areas which you believe are most important in filling this huge gap that you're observing in the national curriculum, which topics are the most important in that sense, and which topics would you like to develop even more as you do the evaluation, see the results, and also perhaps see certain changes that are happening in your country regarding school curricula that could happen in the future? So what's the current priority, and what's your priority for the future? I want to hear specific topics that you want to develop.
So if I would need to highlight 3 topics, I would say the first one would be healthy lifestyle, which includes diabetes and obesity, because unfortunately in Hungary we are around in the top 3, I believe, in both of the conditions. So there's definitely place for improvement there. Second would be substance abuse, because unfortunately we have a huge problem of underage drinking. A couple of years ago, one of the statistics stated that in the European Union, we are again in the top 3, like boys start to drink from the age of 13, mostly, and girls from 14, which is really, really bad. And I think what would be the third one is, I would say, the reproductive health, because that can really impact the youth life if something unaccepted happens. Yes, these would be the 3.
Okay, thank you so much. We have a question from Zeli.
We saw lots of IOs in the presentation. Can I ask how many of them you were able to achieve?
So we were able to achieve all of our objectives and all of our success indicators except one. In one of our local committees, we did not reach the number of classes we were anticipated of having. So the activity, the numbers we stated from based on the population of the cities, and one we didn't reach as many. It might be because of recent negative regulatory changes by restricting who can teach classes to the children in the schools. Therefore, some schools might be more afraid to ask us to facilitate classes for them because it's a very gray area currently in our law.
Okay, we have one more question from Rawan.
Thank you for your presentation. I saw that you put data and about like Google Forms following the sessions about like compliance and willingness of the students to have like follow-up plans. Do you have any long-term tools or strategies on how you could confirm that the students actually went through with these plans or whether they didn't, if you get what I mean?
I do believe that the long-term effects would not be able to evaluate it only by us. I think it's something which we need to look into, like national statistics in a couple of years to see like the increase of blood donations, the rates of underage drinking. So yeah, I think for us, what we can do very easily and what we can do ourselves is the short-term impact, what we can measure.
Okay, thank you so much. Last question. You have 30 seconds left.
Thank you so much for the nice presentation. So my question would be, how do you perform evaluation for this activity? Like it's a lot of people, like 45,000. So how do you perform evaluation? But also, is this activity at a local level, national level, international level? And if maybe it's at local level, do you plan to maybe advance to national level?
Let me start with the second half. It is a national level, although because of our country's geography, most of our classes are in Budapest because the second biggest city after Budapest is 10 times smaller than Budapest. And the evaluation methods is the Google form. We show them at the end of the class. But again, there's another negative regulatory change happening in Hungary recently because children and youth under 18 currently not allowed to use phones in the schools, and for some classes they might allowed to use, but it not always happens for these prevention classes. Therefore, we are trying to figure out a solution for that.
Thank you so much. A big round of applause for IFMSA Hungary. And last but not least, we have our very last activity presented by IFMSA Iran. Habiba, the floor is yours.
For our next activity, under the name Pink Bridge, Pink Bridge is a student-led initiative by IFMSA Iran that connects breast cancer awareness, research, and advocacy into one sustainable model. The project began with awareness campaigns in 4 major hospitals where medical students engaged more than 1,100 community members in discussions on breast cancer prevention, early detection, and screening. To strengthen scientific engagement, Pink Bridge launched the first National Student Cancer Congress, attracting nearly 400 student research abstracts from across Iran. The initiative also partnered with the National Health TV network to deliver evidence-based breast cancer education to a nationwide audience. The purpose of Pink Bridge is to create lasting impact by building bridges between communities, researchers, healthcare professionals, and future physicians. Through collaboration and innovation, it demonstrates how medical students can drive meaningful change in cancer control and public health. Please welcome to the stage IFMSA Iran for Pink Bridge.
FYI, they will be presenting through a video. very short technical break.
women, and nearly 7 in 10 patients are diagnosed at an advanced stage. The real gap wasn't awareness alone, it was the absence of any structured platform. Hello everyone, I'm Parmida Shirizade, presenting Pink Bridge on behalf of our team of 42. Breast cancer is Iran's most common cancer among women, and nearly 7 in 10 patients are diagnosed at an advanced stage. The real gap wasn't awareness alone, it was the absence of any structured platform connecting community outreach, scientific research, and national media into one continuous effort. Following the IFMSA project cycle, we moved from needs assessment and planning to implementation and monitoring to comprehensive evaluation, ensuring every phase informed the next. This led us to our core innovation. Traditionally, awareness, research, advocacy, and media run as separate efforts that end when the event ends. Pink Bridge connects all four into one continuous measurable pipeline, where every stage strengthens the next. Before implementation, we established 5 smart objectives. Hello everyone, I'm Parmida Shirizade, presenting Pink Bridge on behalf of our team of 42. Breast cancer is Iran's most common cancer among women, and nearly 7 in 10 patients are diagnosed at an advanced stage. The real gap wasn't awareness alone, it was the absence of any structured platform connecting community outreach, scientific research, and national media into one continuous effort. Following the IFMSA project cycle, we moved from needs assessment and planning to implementation and monitoring to comprehensive evaluation, ensuring every phase informed the next. This led us to our core innovation. Traditionally, awareness, research, advocacy, and media run as separate efforts that end when the event ends. Pink Bridge connects all four into one continuous measurable pipeline, where every stage strengthens the next. Before implementation, we established 5 smart objectives. Awareness, 900 targeted, over 1,100 reached, 100. Research, 300 students targeted, nearly 400 engaged, 100%. Advocacy, 30 students targeted, 85%. Visitor activation, targeted 60%, achieved 90%. Digital outreach, 15 outputs targeted, 80%. Together, this resulted in a 91% overall achievement across 5 genuinely smart objectives. Evaluation was embedded from the very beginning. We defined indicator before implementation, monitored attendance, and engaged throughout, then combined pre- and post-test, participant feedback, digital analytics, and objective achievements analysis to strengthen the next cycle of Pink Bridge. Our primary beneficiaries were the general population, medical and healthcare students, doctors, and women at high risk, VGOs, health professionals, and the wider IFMSA network benefiting indirectly. To reach them, we united 9 sectors, including academia, healthcare, government, research institutions, media, and youth organizations, creating a genuinely national collaborative ecosystem. This partnership in the 3 implementation phases. First, across 4 major hospitals in Tehran, we engaged over 1,100 community members. Every visitor left a fingerprint on our pink ribbon wall, a physical pledge of support, while physician and patient-led drills amplified the message online. From there, awareness became action. Through collaboration with the Astana Research and Technology Committee, Pink Bridge was officially integrated into the first National Student Cancer Congress alongside the 19th International Breast Cancer Congress, generating nearly 400 scientific abstracts. Finally, in partnership with the National Health TV Network, carried the message nationwide, while our findings were submitted directly to the Ministry of Health to inform future policy. None of this would have been possible without preparation. Before implementation, all 42 executive members completed a structured 6-hour capacity building program, including 3 hours with a brain surgery specialist and 3 hours of team-specific operational training, followed by certification. At the same time, we built it green, screen-first delivery, minimal printing, sustainability as a default, not an afterthought. To ensure financial sustainability, Pinkbridge was supported throughout a local government grant, university support, our internal budget, and in-kind contribution from the Ministry of Health, the Cancer Research Center, and Shahid University, with no dependency on a single core. Beyond funding, Pinkbridge formally advances SDGs. 3. Good health and well-being throughout breast cancer prevention and early detection, while also strengthening SDG 5 through women's health and SDG 17 through lasting partnership across healthcare, academia, government, and media. We also planned for disruption before it happened through a documented risk plan with offline backup content prepared for internet failure. That plan was tested by coordinating multiple institutions, managing a surge of abstract submission, and delivering under wartime conditions and national instabilities, including extended internet blackouts. The plan held our offline materials kept us running. Looking ahead, this year Pinkbridge was local, Tehran only. Next year, it becomes IFMSA Iran's national platform, 10 cities, a larger congress, deeper policy work, broadcast behind a single network, and a replication toolkit enabling every IFMSA animal to adopt the Pinkbridge model. To the 42 who built this with me, thank you. Pinkbridge built a bridge where awareness becomes research, research becomes advocacy, and advocacy becomes lasting change. Thank you for your attention.
Okay, thank you so much, IFMSA Iran. Now it's time for questions. Can you hear me?
Hello everyone, yes, you are audible.
Okay, perfect. For the judges, do we have any questions? Go ahead.
Okay, hello. Thank you so much for nice presentations. This is Sadat speaking. So I want to ask, like, what awareness things you guys used for the event? Were they environment friendly or eco-friendly?
Okay, thank you for your question. And as you see, for this event, mostly we use screens to share our brochures, to share that 400 posters that were sent to us, and mostly we use screens for that. But as you see, this project unfortunately went through a period of instability in our country, and unfortunately sometimes that our internet was shut down somehow. So because of that, we just printed some little brochures that people can see that, because there were no internet to share with them, but it was just to show them so we can be green for this project.
Okay, thank you so much. Go ahead, Ron.
Thank you for your presentation. My question is that, could you please elaborate on the problem that, like, what made you choose this topic and go for this activity in the first place? Yeah.
Great, thank you. So, as you know, based on the studies, and breast cancer is the most common cancer among women in Iran, and mostly based on hospital data, 7 out of 10 patients are diagnosed at an advanced stage. So, due to this, previously some projects, some individual projects for awareness campaign, individual projects for research congress have been held, but no project had connected all 4 pillars for this. We had awareness, we have research, advocacy, and media all together in one project. And also we are going to make it larger this year, and I want to announce it here that 2 months from today we are going to have our second part of this project for this year.
Okay, do we have any more questions? Go ahead, Zali. 1 minute left.
You have lots of like different initiatives at the same time. Can I ask like which evaluation methods you used for each one of them?
Yes, great. So for the first part, as the awareness we had pre and post test assessments for the visitors, as in some Google Forms for that, and it was for our first objective. For our second objectives for our Congress, it was from abstract tracking and post-engagement surveys that we had. For our third objectives, it was mostly some structured interviews with the students, with the healthcare professionals who were there, and also with some interaction logs. For our fourth objectives, we also
Okay,
had
I'm
pre
so
and
sorry.
post
Time
quiz
is up.
assessment.
Thank you so much, IMSA Iran. A big round of applause for IMSA Iran, everyone. And now this officially concludes our Rex Crossley Awards for AM26. Thank you for everyone who came here. Thank you presenters and NMOs for showcasing your impact and always thriving to show what the IFMSA is all about. Thank you to the judges for dedicating their time and their energy towards this amazing tradition. And see you guys in the next for another Rex Crossley Awards. Hello everyone, please stay for the theme event. It is starting shortly. Okay, 5 minutes till the break.
Hello, Anyesa. Can you hear me? Could you please try to speak?
Hi, hello. Yes,
Okay,
I can hear you.
perfect. We are currently have a 5 minutes toilet break. So we will start shortly around 5 minutes, 4:15. I hope
Sure.
you are okay with that.
Yeah, sure. No worries.
Thank you. Okay, for people in the room, I would like to ask you, to kindly ask you to move to the front if it's possible. I know you already have some comfort in your seat right now, but if you're okay, to move to the front, up to the front. Thank you. Okay, hi everyone. Thank you so much for coming to this room. I would like to kindly ask you to sit down properly in the seat that we already have in the up front. I would like to kindly ask you once more time to ask you to sit down into seat places. We are about to start, so please kindly sit down. Thank you. Okay. Thank you so much. Imagine a child born today. Their first health record is digital. Their vaccinations are tracked through an app. Years later, a smartwatch might detect a health problem before they feel any symptoms. Across the world, health data could help prevent the next outbreak before it begins. For many people, this is already becoming reality. But one question remains, will this future belong to everyone? Good afternoon, distinguished guests, partners, and delegates. Welcome to the team event of IFMSA 75th General Assembly August Meeting 2026 from Alma-Ata to Astana Declaration, Advancing Primary Healthcare for Universal Health Coverage. It is especially meaningful that we gather here in Kazakhstan, the birthplace of Alma-Ata Declarations and Astana, where the world will reaffirm that primary healthcare is the foundation of health for all. Today, as healthcare rapidly becomes more digital, our challenge is not simply adopting new technologies. It is ensuring that innovation strengthens capability, equity, empowers communities, and keeps people, not technology, at the center of the care. As medical students and young health professionals, we are not just the next generations of healthcare workers. We are the generations shaping how digital health will be designed, implemented, and governed. We have the responsibility to ask who benefits, who is left behind, and how can we build systems that truly leave no one behind. Today, we are privileged to hear from three distinguished perspectives. DTH Lab will introduce the digitally enabled health system framework and the role of youth as co-creators of digital health. The WHO representative in Kazakhstan will connect the enduring legacy of Almaty and Astana with the global journey towards universal health coverage. Finally, the World Medical Association Junior Doctor Networks will bring the realities from the front lines and remind us why youth leadership is essential in building resilient health system. The future of health is not something we simply inherit. It is something we create together. With that, it is my pleasure to welcome our first keynote speaker from DTH Lab. We have Anya Shamitra. She is the project lead for digitally enabled health systems project in DTH Lab. She will introduce the framework, how digital health serves as an enabler for equitable community-based primary healthcare.
Thank you so much. Thank you so much, IFMSA, for having me here. It's been a pleasure to collaborate with you over the years, also as we were developing the framework over the years. A great warm welcome to fellow panelists as well. I'm just going to share my screen. Just let me know once you're able to see it. Is my screen visible?
Yes, it's feasible. Thank you.
Okay, great. So thank you so much, first of all, for setting that context. You did make my job a slightly easier in terms of setting the context for how primary healthcare is important for universal health coverage, and also why we need to next look at digitally enabled health systems in order to strengthen our primary healthcare. So as we all know that our current primary healthcare does have certain challenges, and as we look at the future, it is important that we look at digital health as an enabler or as a tool that where we are looking at technology in supporting and strengthening the primary healthcare systems. And this doesn't really mean that we're looking at just embedding technology as it is, but rather looking at embedding it in the larger workflow of our primary healthcare so that it supports different facets of primary healthcare in the current workflow that exists. And that is only possible and rather useful in strengthening universal health coverage, promoting universal health coverage only if we create equitable and inclusive health systems transformation. That is where I bring forward and introduce the framework for digitally enabled health systems. And this is a framework that was developed by Digital Transformations for Health Lab, targeted at health leaders across various nations in terms of ensuring that they understand how do we address young people's needs as we look at digital transformations for health and creating digitally enabled health systems. Now, young people really become important because as a age group, right from ranging from 10 years where we begin as adolescents to 29 years where we are entering, where we are towards like the adulthood. It becomes important because this as a group becomes the prime user of digitally enabled health systems, and which is why designing systems in a way so that this age group's needs are taken care of becomes equally important. A little bit of background before I go into the framework, just to set the context on how did we come about creating the framework. So over the last 4 years, until 2026, where we launched the framework, we have been speaking with almost more than 600 plus young people who have been in the age group of 18 and above, between 18 to 30 years across 80 countries and ranging from 16 youth-led organizations. And the objective was to really understand what the vision of young people is when it comes to their digital health systems. Then we also looked at national digital health strategies accessible via the WHO Global Repository. We were able to identify 87 national digital health strategies out of the 125 countries that currently have national digital health strategies and documents that support these strategies. What we found was 57% of these countries did not reference young people's needs or mention initiatives that would cater to the unique needs of young people. And the 43% that did so in a very broad manner, mainly in initiatives that were focused on maternal or child health or immunization programs, etc. Which is why we put together the framework for digitally enabled health systems in a manner so that it is responsive to young people's needs. And this framework essentially comprises of 8 levers, as we call it. The 4 levers on the right talk about what should a digitally enabled health system include so that it benefits young people. And the 4 on the right talk about how these systems need to be designed so that they benefit young people. I will go through each of the levers a little bit. I will touch upon each of them a little bit. so that I'm just able to explain what they really, what are we recommending under each of these. So the first one is on integrated digital health solutions. So when we were talking to young people, what we really understood was that the need is for having an integrated solution for across different health needs of young people, so that it's aligned with needs around mental health, reproductive health, or climate health. And it is delivered in a manner so that it's integrated rather than standalone health solutions, which is where interoperable care pathways for personalized and age-appropriate care became really important. And also having these services catered to the evolving needs across the life course of a young person was also advocated very strongly, which is what also forms the basis for recommendations around having integrated digital health solutions. The next one was around embedding it in learning and training environments. So now a lot of evidence does tell us that young people as an age group do not really access healthcare in the manner in classical ways, and would rather find it more useful to have it embedded in their own surroundings, which is where we have seen programs that are part of schools or universities or even workplaces or community settings where young people are already embedded or are already part of. Having digital physical linkages in these environments really help uptake of health services. So that is something that we are also promoting for digital health systems. Having institutional integrations and also multi-channel modes for those that are not part of institutions is important in order to ensure that digital enabled health systems are also embedded in daily environments of young people. Secondly, capacity building just beyond health workers, looking at community leaders or community workers, as well as teachers that are part of schools or universities in a way so that they are at least able to act as first point of contact for young people becomes important. The next is the third lever, which talks about literacy for digital health, AI, and social media. Now, we all know that as young people, we do have multiple sources for accessing health information, and these go beyond just health workers. Like we do, as an age group, we do have access to AI chatbots, other generative AI platforms, as well as social media. And because of this, it becomes really important to enable and empower young people so that they're able to access, interpret, and also safely engage with digital health informations and services. Then next is the workforce capacity building for young people's health. Now, as future workforce and future health leaders, you would understand that it's not just about being confident in using digital health tools or being clinically competent, but also being sensitive to the needs of this age group, because there are also a lot of services that they need or areas that they need help with that are still that also attract a lot of stigma even in today's day and age. So it's also important to have youth-sensitive workforce and along with having clinical competence and digital tools confidence. Then I would move on to the next set of levers, which talk about how a digitally enabled health system should be designed. And the fifth lever in this is about young people's participation and governance. Now, I guess as IFMSA and also as DTH Lab, we have been advocating for institutionalizing youth participation. Now, how do we really do that? So the framework recommends that we have institutional roles and responsibilities and have young people as part of advisory committees, existing advisory committees or systems that are really responsible for designing health systems, and have them embedded in processes right from design to implementation as well as delivery. So having institutional participation of young people becomes really, really important in order to ensure that the systems that we create remain responsive and aligned with young people's needs. Then the next is equity and accessibility. So it is very important and central to digitally enabled health systems so that we ensure that we are reducing rather than reinforcing existing disparities in access to care. And because of this, it's very important that a people-centered design approach is adopted when digitally enabled health systems are being created in different countries. And at the same time, having them secure and developmentally appropriate for young people is equally important. The next one is data security, privacy, safety, and accountability. Now, trustworthy digitally enabled health systems become trustworthy only when they have strong safeguards, they are transparent, they provide transparent governance, and have youth-centered protections. As part of this, we advocate for privacy and security by design with stronger protections for health data. We also talk about youth-responsive AI governance and technical standards. This primarily becoming important, and also I think we can draw lessons from how we're facing challenges across the globe for regulation of social media and its impact on young people. So from that point, it's important that from the beginning we have responsive governance and technical standards built into the digitally enabled health systems. I come to my last lever, which is around monitoring, evaluation, and continuous improvement. One of the most important things around this, and the key message around this, is that in order to ensure that the systems remain responsive, accountable, and continuously improve, it's important that we have very strong monitoring, evaluation systems. And right from ensuring that the products and services that are designed, also programs that are designed, they are evaluated and in order to understand whether they are addressing young people's health needs or not. And lastly, also the data generated from these need to be leveraged for system improvement on a real-time basis. That would be all from my side. This is the QR code for the report, for the framework. Happy to also share it in the chat once I stop sharing the screen. But I would like to pause here and see if there are any questions for me. Thank you so much.
In this room, people are clapping their hands. So you might be, it's not audible because we don't have, room microphones. We only have like personal microphones. They seem very enthusiastic with your presentations. And I've been already collected questions that we receive. So there are some pillars, there are some levers that you have been mentioned. As a youth, as a young person in this current AI generation. So we have a questions about, is there any one concrete actions that very visible, like would say short-term actions to enable the digital health system?
Right. Thank you so much for that question. I think I will go to the workforce capacity building lever over here. And I say this mainly because as future workforce, as you enter the workforce, you might see a little bit of lag between your medical curriculums and versus what is the need of the hour, right? So one of the concrete, this would be a personal suggestion rather, would be to like be proactive in terms of also learning what digital tools are currently coming in, what are those capabilities that you need to have as you enter the workforce. Just being aware of what are the systems that you need to deal with as you enter the workforce, as well as building an understanding so that you also act as an advocate in the future for having sensitive as well as competent digital tools or digital systems would be really important. So I guess as individuals who are going to enter the workforce in the future, just being aware of what are the recent, probably in your country context or in your subnational context, what are the digital systems that are being implemented, just being aware of those, taking some personal initiative to learn those, as well as being aware of what are the challenges so that you are able to challenge them, or rather provide your inputs going forward would be a right way to go. Because just adding one more point, I think that capacity building is the first step for anyone for being also a competent or an effective advocate for the services that this group deserves. So capacity building would definitely lead to also competence, and then would also make you great and strong advocates in the future. Thank you.
Thank you so much, Agnieszka, for explaining. And I also personally agree about like capacity building is the first step. It's the cornerstone to understand an issue, topics, especially in the digital health, in this current new technology, a lot of new technology era that has been developed, especially in the artificial intelligence. If I could give 1 minute, like one last message from DTH Lab for the youth. What should we do for the enabling digital health system as a clinical medical students that we are working in the healthcare system?
I'm sorry, I lost you for a bit. Could you just repeat the question one more time for me, please?
Okay, thank you. So I would like to give you a minute, like to give us as a young person a message. How should we do as a medical students, especially for us that enrolling or like attending a hospital rotation, because it's health systems, what we can actually do?
Right. Okay. That is quite a tricky one, yet a simple one at the same time. Tricky because I mean the systems are so complex in itself. So giving like one suggestion or talking about it in 1 minute can be quite challenging. Nevertheless, I think one important consideration that I would like to leave the group with today is that think of digital health systems from a holistic point, and where you bring in your knowledge of you bring in your clinical knowledge, you bring in your digital capacity building, or your basically your knowledge and skills in handling digital health tools, as well as the human-centered approaches that really impact your patient at the end, right? So just ensure that as you are attending to your patients or also treating people as you enter the workforce, just ensure that you maintain a balance of all the three, because they are really important, so that you are able to deliver services in a manner that's most useful for young people. Because clinical competence, each of these components, they are equally important, and one shouldn't lose out the human aspect as well. So that would be like my 2 cents about what you should really focus on.
Thank you so much once again. Thank you so much, Agnieszka, for spending your time to give some insights to us as a young health professionals, future young health professionals. For participants here, if you would like to learn more about digital health, you can visit the DTH Lab, and there's some opportunities, there's some new insights, a lot of resources related to digital health. So you can visit to their social media as DTH Lab. Once more time, thank you so much, Agnieszka. If you might have more time, you can say, but if you are not, feel free. to leave the space.
No, I don't have anything more to add. Thank you so much for this. I'm just going to leave the link to the framework and also our socials in the chat. I would also like to encourage everyone to join the My Health Futures Network. It's a LinkedIn-based group of young professionals in digital health, which is a great platform for young professionals, not just to capacity build, but also work with peers in different areas that relate to digital health. That would be all from my side. Thank you.
Okay, thank you so much. Roger that, we will share into the announcements of our delegates group chat. Thank you so much one more time. Thank you. Okay, so we are going to move to the next agenda, which is the panel discussions. We already have our two distinguished speakers, our amazing speakers, that we will learn more about digital health integration, implementation barriers, and empowering youth from advocacy to system-level impact. I would like to introduce you to Mr. Yerbol Spatayev, MD, MPH. He is a public health and digital health expert at the WHO country office in Kazakhstan. I would like you to introduce more about yourself. Feel free to say hi.
Okay, guys, good afternoon. It's a real pleasure for me to see you, although you're a little bit tired from acquiring new knowledge, as I can see. But I hope we will a little bit maybe wake you up with my esteemed colleague here. So my name is Yerbol. I am a medical doctor by background, but for the last almost 20 years, I'm working on digital health primarily. So not only digital health, but digital health implementation in different settings for different projects, for different areas within the healthcare system. So here we are going to talk about primary healthcare, and you know that Kazakhstan is the birthplace of two important documents of WHO and globally. It's a PHC declaration of Almaty and the PHC declaration of Astana. Those are two very important documents I hope we will be able to discuss.
Thank you so much, Mr. Yerbol. We do have second speakers, Dr. Giazul Ponce. She's also IFMSA alumni. She's from World Medical Association Junior Doctor Network, WMAJDN. Would you like to share more about yourself?
First of all, thank you so much for being here. I mean, everyone looks very tired. I know how you feel as alumna that I am. I was a part of SCORA 10 years ago or more. So, well, my name is Jesús Ponce. I'm from Mexico and Spain. I'm a general practitioner, but also I did my specialization in public health and medicine preventive with my PhD. And right now I'm working in a primary healthcare in a rural area in Spain. So for me, it's very interesting to be with all of you to share my youth perspective, because I'm not so young as all of you, but I'm still young, think so. So thank you so much for inviting me.
Thank you so much once again. So I would like to also let you know, if you still have any questions in the meantime, there's a Slido link that has been shared in the group chat in the announcement chat of the participants. So we will collect the questions from that. With the previous questions also we collected from the form. Due to time efficiency, that's why we collected from the form. Thank you so much. If you have a hand raised, please type your chat. Type your questions in the Slido link. Thank you. Moving forward, we will talk about the gap between policy and reality. So I would like to know more from Mr. Yerbol from WHO Kazakhstan. Despite the clear roadmap, Despite the clear roadmap laid out in the Astana declarations, many health systems remain heavily hospital-centric. That's also happened in my country. And fragmented. What are the primary structural and political barriers preventing countries from meaningfully shifting investment toward community-based primary healthcare?
Yes, thank you very much. This is incredibly important question indeed. And not only in your countries, but in many other countries across the world, we see the same situation, that there is a declaration, there is a sort of political will to move from hospital-centered to primary health-centered systems. However, there are multiple reasons why it is not happening, because there are enough evidence which demonstrates that only with strong primary healthcare system we can really reach the target of achieving universal health coverage. We know that for sure. There are evidence across the world, but knowing something and following this knowledge, those are two different things. I'm sure that many of you have relatives or close friends who are smokers. These people know that smoking is very bad for health. However, they continue to smoke. Unfortunately, something similar is happening with the healthcare system across the world. We know that we should move towards stronger PHC, however, we still continue supporting and investing in hospitals, which is okay. I mean, we cannot survive without hospitals. We will have patients anyway, right? We will have diseases, and we were trained for decades, for ages, for centuries to deal with diseases. But the new paradigm of health means that we have to address not the separate disease in separate person. We have to address the person itself because according to the most famous definition of health, what is health? Health is not merely the absence of disease. It's a much broader definition. So, and in order to achieve this state, it is only possible when primary healthcare is really functioning proactively, is really multidisciplinary, is really engaging not just addressing the existing health needs, but addressing prevention and also social aspects of healthcare services. So the problem here is that, historically speaking, our healthcare system were built around hospitals. And from political perspective, it's much easier, it's much more attractive to do a sort of a quick win, to build a new hospital, to buy a new expensive equipment, new CT scan, new MRT scan. You can make a photo with this, you can publish it on social media, you can publish it on paper, on somewhere. This is very attractive for politicians, this is very attractive for donors. It's much more easier to do than to recalibrate the healthcare system, recalibrate financing of the healthcare system, develop and introduce new rules, new SOPs, new procedures. And you cannot really show, you cannot really brag around new processes, you cannot really brag around new prevention mechanism, because they provide the real output in years from now. When you treat a specific person with some heart disease, with some significant problem, with some significant condition, you see the result immediately. It seems much more rewarding. That's why we're continue to revolve our healthcare system around hospitals. It is not easy to really switch the financing from hospital-based towards PHC. All of these questions, all of these problems are still continue to push dominating this specialized hospital system rather than investing more in PHC, unfortunately. That's the reality.
Thank you so much. I would like to know more from WMA JDN perspectives. So as a young medical professionals on the frontliners, what do you see the most significant gaps in PHC implementation today?
First of all, we need to try to understand one thing. Youth people around the world face many huge and hard realities. Right now, we are seeing low salaries. We are seeing also temporary contracts. We are seeing also even it's more difficult right now to be independent and have a more stable life. It doesn't matter what do you study. The world right now is a little bit more harder to live. And medicine also is changing right now because right now doctors are not choosing only on vocation. We are trying to find the equal a balance in our life. We need the time for live, but also we need to get money for continue living. So it's true that the primary health care, it's not only about doctors, it's also about nurses, it's about healthcare professionals. We are a team at the end. But if we do not have better working conditions, if we do not have a safety environments and also better salaries, also this becomes a very a barrier for, I mean, it's less attractive for youth people. So finally, many youth doctors decide to choose other specializations, other specialties, dermatologists, plastic surgeons, and this specialization is not means that it's not important. For sure are important, but what we're gonna do without family medicine doctors? What we're gonna do without nurses? What we're gonna do with emergency doctor? What we're gonna do with the general practitioner who has to go to the rural areas that no one wants to go because they need to spend even more money than their salaries that they receive. So this also produced brain drain. In the past, we could see brain drain from low-income countries to high-income countries. Right now, we are seeing a new phenomenon. We are seeing that also, even into Europe, we can see move from, for example, from Spain to UK, because in UK they don't have a night shift of 24 hours, for example. In Spain, there still exists. We can see Greece, people from Greece to move from Spain, because in Greece, Spain have more better salary than Greece. And also we can see Latin American doctors moving from these countries to Spain because they do not have this language barrier. At the end, we speak everyone Spanish. So right now, it's not only about rich countries and poor countries. We can see many social structures and infrastructures that influence in our decisions to move. So I think definitely that right now young doctors are less willing to accept poor working conditions that in the past many doctors normalize.
Okay, thank you. Would like to move more about the digital health as enabler for the universal health coverage. What are some practical examples how the digital health is successfully reorienting PHC to be more preventive, despite a lot of NCDs that coming up right now, aging populations as well?
Yes, thank you very much for this question. That's true that digital health can be an enabler for more proactive, more oriented towards prevention primary health care, but there's really not that much of fancy thing we need to ensure in terms of digital tools for primary healthcare to become really proactive and become really oriented towards prevention. At the level of people who are making decision on how primary healthcare is structured and delivered, policymakers, Ministry of Health, we need them to have a simple access to very simple tools such as dashboards, analytical databases, so they can really understand the demographics of the population they serve, so they can really understand the health profile of the population they serve. This is basics which digital health can ensure, like in many settings across the world. If we speak about health providers themselves, it's very important to give them the digital tools that will help them to stratify their own population. They have to know, they have to see with the help of digital tools what people are at risk, who should be proactively addressed first, who should be contacted, who is at risk of developing a disease, who is at risk of developing complication of some existing disease, who should be and in what time should be, for example, invited to get a flu vaccine or any other immunization or any other treatment or prevention service. At the level of population, digital health can also provide very simple tools such as proactive notifications for people. It's basically the same. It's connected with the tools which PHC providers have. So it's really nothing super fancy. Probably you expected that I will talk about AI. It's not even so necessary. Yes, of course, AI is great, but there are many other tools which can support clinical decision-making at PhD level. And they're quite easily to implement. The problem with digital tools is not that they are not available. The problem with digital tools is that they remain to be fragmented in many countries across the world. There are plenty, like dozens of different tools which healthcare providers should use, and they are not always well integrated. They are not always sharing the data, the same data about the same person, about the same disease across those tools. And this creates a lot of complication. This creates a lot of fragmentation. This creates a lot of problem with the promise brought by digitalization into PHC. So those are challenges, those are promises. Thank you.
Thank you so much. Yes, I do agree. Like some part about like digital tools are there, but clinical decisions making are still more important, despite a lot of sadly, but fortunately and unfortunately as well, like a lot of health professionals now using AI. Yeah, that's why I would expect more about AI literacy a bit in health, but that's okay. Let's move on a bit about youth leadership and system level impact. Young healthcare professionals are highly engaged in advocacy, but often lack in decision-making power, sadly. What specific institutional changes are necessary that you think to empower youth to move from advocacy into tangible system-level impact?
No, it's very interesting actually, because we are here. I believe that even youth doctors are more engaging right now after a long time ago that I've been here in IFMSA. Actually, IFMSA is one of the good examples for amazing platform that you can raise your voice and you can even be a part of the advocacy and policy maker decision. I mean, at the end, you doctors and medical students have to participate and get involved more in this taking decisions. But unfortunately, we can continue seeing a lack of participation of the clinical doctors. For example, even they don't get involved in their unions in the local cities, for example, or sometimes it's because, this is very important to mention, the workload. The workload is a barrier that's why the many doctors are not getting involved in these taking decisions, because you finish tired. I mean, at the end, you cannot attend 50 or 40 patients in your shift in 7 hours and then dedicate time for be a part of taking decisions. So there is a structure that probably medical students and also you doctor has to participate more and raise their voice of these doctors that I cannot do that, because even many doctors, they don't know that I can do. So I think that probably we need to be more considered by governments as a youth doctors, as a medical student, because sometimes governments take decisions after they already made some policies, and many politicians have never been attending absolutely nothing. So it's very funny how they try to implement some policies and they don't know the reality of the youth doctors or medical students are living. So definitely IFMSA, WHO, all of these platforms are very nice, but also we need to try to work more in a local perspective in our cities as well.
Okay, yes, this is because I used to also attend one of the World Health Assembly, and I was part of IFMSA as a non-state actor delegation, but at the same time, I was also youth delegates from Indonesia. This quite different experience at the same time, like how I see, like how if youth included in the part of state delegations, they have more spaces. Like as simple as they have more time when we deliver the statement. So that's a point. So I think it's currently more opportunities for you to be engaged with their government. That's the thing that we need to appreciate more. Okay. So I'm going to I have received questions. So this is both for WHO, for Mr. Yerbol and Dr. Jaya. This is about how can healthcare or medical professional business enthusiasts overcome early clinicians or health professional resistance to critical digital tool implementations? And what are the strategic framework guarantee long-term adoption in hospital and clinical settings? Would you like me to rephrase? Okay. Or
let me try to address. I think that our first speaker, she demonstrated quite interesting framework for bringing digital health into forefront, and I really like the way that this framework covered not only digital tools themselves, because just having some digital solution does not mean that this solution will really work and will really bring any impact towards better care, more quality care, more accessible care, better health outcome. Nothing is guaranteed. You have to deliver some infrastructure. You have to deliver some standards and interoperability. You have to deliver human capacity, knowledge and skills. You have to deliver legislation which will support implementation of this digital tool. You have to deliver a lot of non-digital environment surroundings to make digital transformation happen. It's not just some magic AI or machine learning or blockchain or whichever technology we can imagine. Technology alone is not making difference. Believe me, it's an experience of dozens of years of implementing digital health across the world. The digital, the very best digital tool you have, you implement it in 2 different hospitals, you implement it in 2 different countries, you might have a drastically different result. So a lot, the question was about how to do it, not what are the problems. So really leadership at the grassroots level is the key, I think. If there are leaders, informal leaders, who really support digitalization, it can happen. We saw a lot of great examples of that. So leadership, governance, standards, capacities, infrastructure.
Me, I would like to add, just reply on this. It's very interesting, the whole of these things, but it's important to mention the digital implementation. We cannot forget that we are living in a transition of generational transition from analog to right now AI. And we cannot use this digital implementation like a supplier doctor, for example. And I think that we are seeing this huge mistake of even some students on other careers. I mean, we cannot suppliers with the AI or the another tools. We can use these tools to improve or even become easier our job, but we cannot supplier our knowledge or the medicine school knowledge that we are got it. I mean, and it's important also mention that we need to consider the structural barriers and the structural social determinants for implement these digital tools, because for sure we can, if we can try to apply for this for the whole places in the world, we can create even new inequalities, new gaps. It's not the same to try to implement digital healthcare in a country which is not even have an access in a rural area to internet and another that they do. So I think this is the only that I would like to add, because it's very important to mention that digital health is important, but also we need to consider structural and social environment.
Structure. Nice. Thank you so much. I would like to highlight about the structural and structural and social environment, because like it always depends how's the setting between us, how's the situations and the community around us as well, that are they ready for digitally enabled primary health care systems or not. I mean, but however, like in this current, I would say most of the spaces already being digital, but depends like what level of digital that they have been raised. If I remember, like when we were kids, we just have computer and emails. Now we have a lot of socials channels that also might related to the health promotions and tackle the misinformations. So yeah, would you like to add or? Okay, thank you so much. We are coming to, due to time constraints, unfortunately, we are coming to the last part. It's about the call to actions to both Mr. Yerbal and Dr. Jaya. It's looking ahead to the next year, 2027 UN high-level meeting on universal health coverage. What is the one most critical commitment that you want to see member states regarding digitally enabled primary healthcare? Yeah, do you want?
Okay. I answered several questions before and I omitted artificial intelligence. But now, I mean, you mentioned that we're living in AI generation world, right? So we cannot just ignore it, we have to embrace it. And implementation of artificial intelligence in health is very promising, yet extremely difficult. And you might have seen already hundreds and thousands of scientific papers published regarding the AI implementation. However, not that much of a difference which was brought by those tools into the real life impact. So we have to embrace it in a very meaningful way. We have to implement the very good data standards for that, because we know that AI is as good data we feed it to learn and to train. So we just need to unify our efforts towards better implementation of AI, because now it's still just a promise. Thank you.
Thank you.
Also, I would like to mention that it's very important for sure investing in digital health for the, yes, because as I said, we can improve our medical record, we can facilitate our work, but it's true that also we should strengthen the primary health care for sure, but also we need to don't forget the medical education. Why? Because we are continue having some medical programs with 20 years, for 20 years long, I mean, more or less. I mean, even we cannot forget our senior doctors for sure, that probably they are not more involved in the AI and all of this new technology. You know, I mean, I would like to say Facebook right now is like a huge database of boomers, you know, so we can see this transition for Instagram, TikTok. So right now, I think that we need to engage and try to work in medical education. We need to try to involve the senior doctors as well. Even that's why the junior doctor exists, because we are a part of the WMA and we try to work and collaborate together. So it's very important to mention that this is a transition from analog to right now a new technology that it has to implement for facilitate the work, not for create inequalities. So this is very important that it have in the next UN level has to face, definitely.
Thank you. I do want to highlight about, do not forget the medical educations before and health professional educations, because that's the start point of how the primary healthcare and the healthcare system as a whole shaping on it. So as a human resources that build that, even we have AI, but AI cannot be human. That's just artificials. So that's why I would like to highlight, do not forget the educations before, because everything starts from the educations. I just would like to wrap up our short conversation. Sadly, we cannot talk more due to the time constraints, but I hope we will have some time more to talk outside this panel. One thing that becomes clear that the future of primary healthcare will not be built by the technology, by AI alone, but by how we prepare people to use it responsibly. So we need the educations. Artificial intelligence and digital health are extremely promising, but as Mr. Yerbal said, it's still just a promise. They have the potential to strengthen prevention, to support clinical decision-making, but again, AI cannot be empathized like human. Even you can ask AI, make it the wordings more empathetic, but they are not human. They don't have feelings, they don't have gesture, they don't have face mimic that can deliver empathy to others. However, the journey from innovation to real life impact is complex. This is why investment in digital health must go hand in hand with investment in our healthcare workforce and medical educations. We must embrace the innovations while protecting the human connection that defines healthcare. The goal is not technology replacing people, but technology empowering people, building a digitally enabled, resilient, and compassionate health systems where no one is left behind. So, my name is Alfa Fatia. I'm the IFMSA Vice President for PR and Communications. I would like to thank the panel speakers. So we have some souvenirs to bring you back home to have some, but let's wait a minute. I'm gonna take that. We would like to have a picture together. And
Me as well. Yes. Thank you so much. Go, go, go.
yes. Okay, thank you so much to our panelists. We have a short 15 minutes workshops. As I said in the group chat, we will have very simulative workshops that, wait a moment, let me share my screen.